Hi, good afternoon, everyone. I was tasked to choose wisely on the topic of neoadjuvant therapy. Of course, neoadjuvant therapy does not only mean neoadjuvant chemotherapy, it can also mean endocrine therapy and radiotherapy, and now, of course, immunotherapy. So, cancer remains to be among the top three causes of death worldwide. The most common cancers occurring, of course, is still breast, lungs, and colorectal, with mortality highest among the lung cancer patients, as well as liver. In recent decades, evolution in the approach to the treatment of cancers have significantly improved outcome of these patients, thankfully. One particular treatment approach of significance is the application of neoadjuvant treatment. So what is neoadjuvant therapy? So it's giving treatment before definitive surgery, before definitive RT, and of course, it has its advantages. It may convert an inoperable tumor to surgically curable condition. It may reduce the extent of surgery, so you can have organ preservation. It allows to evaluate short-term response to given therapy and change treatment scheme if alternate options are available. It can also show early control of systemic cancer disease. As we know, cancer is a systemic disease at the outset in most solid tumors. It's an excellent tool for translational research and accelerated approval of novel therapies. And it also gives you a sense of the in vivo sensitivity to chemotherapy or systemic therapy of your cancer. Of course, there are disadvantages. There can be persistence of gross tumor bulk during few months of therapy, which may increase probability of forming metastatic clones. It can sometimes be mutagenic and may facilitate tumor evolution. It can result in selection and expansion of resistant tumor clones, and small tumor foci may be missed during surgery and remain in the body. Of course, our first is breast, which is the #1 cancer. These are the candidates for preoperative systemic therapy. Patients with inoperable breast cancer, those with inflammatory breast cancer, those with bulky or matted clinical N2 axillary nodes, those with clinically N3 nodal disease, and of course, clinically T4 tumors. Also, even in select patients with operable breast cancer, those with preoperative systemic therapy is preferred for HER2 disease and of course triple negative breast cancer, of clinical T2 or clinical N1. Large primary tumor relative to the breast size in a patient who desires breast conservation, clinical node positive disease likely to become clinically node negative with post-operative systemic therapy. So preoperative systemic therapy can be considered also for clinical stage 1C, HER2 positive disease, and triple negative breast cancer. And of course, in those patients in whom definitive surgery may be delayed for other reasons. So these are the NCCN guideline version March 2023 for invasive breast cancer. And highlighted here is high-risk triple negative breast cancer, where the new checkpoint inhibitors, preoperative pembrolizumab plus carboplatin plus paclitaxel, followed by preoperative pembrolizumab plus cyclophosphamide plus doxorubicin or epirubicin, followed by adjuvant pembrolizumab. So this is the Keynote 522. This is for early triple negative breast cancer. It is a phase 3 trial, median follow-up of 39 months. The neoadjuvant phase is composed of pembro plus carbo plus pacli, cycles 1 to 4, and then plus doxor epis and cyclophosphamide cycles 5 to 8. And the other arms, of course, placebo plus the same chemotherapy. Inclusion criteria: patients age over 18, newly diagnosed T1C N1 to 2 or T2 to 4 and 0 to 2 triple negative breast cancer, ECOG 0 to 1, tissue sample available for PDL1 testing. They were stratified by nodal status, tumor size, or carboplatin schedule, whether every week or every 3 weeks. The primary endpoints were pathologic CR, YPT0, TIS, YPN0 by local review, EFS by local review, and secondary endpoints are pathologic CR, OS, EFS, PDL1 positive, disease, and safety and quality of life. And exploratory endpoints are residual cancer burden, pathological CR by subgroups, EFS by pathologic CR. So these are quite a big number of patients. This was randomized 2:1. So 784 patients for pembro plus chemo versus 390 for placebo plus chemotherapy. Median age is 49. They were very young patients, as young as 22 years of age. Performance status PS1 in 13 and 12, so they're equal in almost both. PDL1 status with CPS more than 1 in 83 and 81%. Carboplatin schedule 57 in every week and 42 in every 3 weeks. T1, T2 mostly 74% of patients, and more than half are node positive. So if you look at the definitive PCR analysis to test the primary hypothesis of pathologic CR based on a pre-specified first 602 patients with a pre-calculated p-value boundary for significance of 0.003, and it showed consistent benefit seen with pathologic CR defined as YPT0, YPN0, and YPT0 and TIS. So if you look at the 13.6 difference of 64.8% and 51.2% of pembro versus the pembro plus chemo versus the placebo. And if you look at the pathologic CR by disease stage, if you look at the stage just from stage 2A to 3B, you see the big difference in the pathologic CR as the stage becomes more advanced. 25.6 for 3B, 24.6 for 3A, and only 11 for stage 2A, and 7.8 for stage 2B. So for the pre-planned interim analysis for EFS, the first, based on 1,174 patients, again, hazard ratio is less than 0.4 and median follow-up of 15.5 months. About the RCB, or the residual cancer burden and adverse events, if you look at the RCB0, the pembro plus chemo is 65.6 versus 52.7, and RCB3 is higher for the placebo plus chemotherapy at 8.5 versus 4.5. Adverse events, there are more with the pembro-containing arm at any grade at 32 versus 10.8, and discontinuation is 6.5 with the pembro versus 0.8 for the placebo. And then, of course, immune-related are mostly seen in those within the pembrolizumab arm, with the most common being hypothyroidism. So in conclusion, Keynote 522 showed us that neoadjuvant pembrolizumab added to chemotherapy was associated with a higher pathologic complete response rate and fewer patients in the higher RCB categories. Among patients with early triple-negative breast cancer, the percentage with the pathologic complete response was significantly higher among those who received pembro plus neoadjuvant chemotherapy than those who received placebo plus neoadjuvant chemotherapy. Now we go with HER2-positive breast cancer. So if you look at the preoperative adjuvant therapy regimens, it's a long list of paclitaxel, trastuzumab, with pertuzumab, and of course, useful in certain circumstances. Of course, there's always taxanes, TDM1 in the adjuvant setting only. So these are in March 2023 NCCN. The TRAIN2 is a neoadjuvant chemotherapy plus or minus anthracycline with dual HER2 blockade in HER2-positive early breast cancer. This is a multi-center randomized phase 3 study in the Netherlands where treatment-naive patients with HER2-positive stages 2 to 3 breast cancer with an ejection fraction of more than 50%, 438 patients in all. The first arm is pertuzumab plus paclitaxel plus trastuzumab and carboplatin at AUC 6, that's 9 cycles. The other arm is FEC followed by taxane plus pertuzumab every 3 weeks, and then PTC plus pertuzumab also every 3 weeks, followed by surgery and then adjuvant chemotherapy. Primary endpoint, again, is pathological CR by local assessment, and these are the secondary endpoints. As you know, anthracyclines are a standard component in the treatment of breast cancers. In this study, they want to see if there's a possibility of not giving anthracycline. These are the baseline characteristics. They're the same. Most of them, 68%, are clinical stage T0 to 2 in 70%, stage 2 in 69%, and about 60% of them are ERPR positive, and the tumor grade, about 86% are tumor grades 2 to 3. So if you look at the pathologic complete response for all patients, it's the same. It's not significant. The p-value is not significant. For ERPR negative, 89 versus 84, again, it's not significant. And then for ERPR positive, it's 51 and 55%, again, not significant, with the two chemodrug combinations plus trastuzumab and pertuzumab. So if you look at the subgroup analysis, all patients are almost the same. They're all in the same line of unity. So ERPR receptor, FEC2, and then so the pathological CR, and it's the same for in terms of the PCR. In terms of cardiac safety, the FEC followed by plus T plus pertuzumab is 29, with the ejection fraction less than 50% and only 17 for the PTC plus PER2, and this is highly significant at 0.003. And then, of course, others are left ventricular systolic dysfunction. There was MI in the PTC plus pertuzumab. So their conclusion, in treatment-naive patients with stage 2 to 3 HER2 positive early breast cancer, efficacy of neoadjuvant anthracycline-containing versus anthracycline-free regimens with dual HER2 blockade is comparable. The study did not meet primary endpoint, but the pathologic CR rates were high, 67 to 68%, regardless of the treatment arm. Febrile neutropenia, left ventricular ejection fraction decline significantly reduced with the anthracycline-free PTC regimen. Study investigators conclude that anthracycline-free regimens may offer treatment alternatives for HER2-positive early breast cancer in neoadjuvant setting. But of course, what we know more are the pivotal studies on neoadjuvant TRUST-2 plus PER2 for patients with HER2-positive early breast cancer. So who will not forget NeoSphere 2, which is for chemo-naive women with HER2-positive early breast. So randomized to TH, THP, HP, and TP, and then followed by surgery. And of course, phase 2 again, the Trifina cardiac safety study using dual HER2 targeting plus or minus anthracycline treatment. So NeoSphere, it shows you the pathologic complete response with the pertuzumab, paclitaxel, and Herceptin at 45.8%, higher than the rest with the TH, the HP, and the trastuzumab and pertuzumab. And then, of course, the Trifina by ERPR status, you can see that there's 79.4 for the FEC plus HP times 3, followed by THP times 3, 79.4 versus 46.2 for the ERPR positive, so higher for the ERPR negative. And that's true for the other combination. The ERPR negative shows a better PCR than the ERPR positive. So in conclusion, these two phase 2 studies given neoadjuvantly, the combination of PER2 plus TRUST2 and standard chemotherapy resulted in low rates of symptomatic left ventricular systolic dysfunction. NeoSphere, PER2 plus TRUST2 plus docetaxel had significantly improved pathological CR compared with those with given trastuzumab plus docetaxel without substantial differences in tolerability. Now we go with rectal cancer. So this is the NCCN on the treatment for neoadjuvant therapy for rectal cancer. So we go with PRODIGE 23, neoadjuvant chemotherapy with FOLFIRINOX and preoperative chemo-RT for patients with locally advanced rectal cancer. This is a multi-center randomized open-label phase 3 Stratified by treatment center. Of course, the treatment center always has an important role because depending on the quality, the skill of the surgeons, uh, the treatment center is always a factor. The tumor stage, the nodal status, extramural extension, tumor location, centimeters from the anal verge. So patients were aged 18 to 75, resectable clinical T3, T4, less than 15 centimeters from the anal verge, performance status 0 to 1, no metastatic disease, no prior pelvic RT or chemotherapy, no perineural invasion, greater than grade 1. So they were randomized to a modified FOLFIRINOX plus CRT plus TME, followed by adjuvant chemotherapy for 3 months. And the other one is CRT plus TME, followed by adjuvant chemotherapy for 6 months. So modified FOLFIRINOX is administered for 6 cycles over 3 months. CRT is 50,400 gray, 50.4 gray over 5 weeks plus capecitabine, and TME is performed 7 weeks after completion of your CRT. And then your adjuvant chemotherapy is mFOLFOX6 or capecitabine. Primary endpoint is disease-free survival. Secondary endpoints as follows, and median follow-up is 46.5 months. So 230 plus patients, more 65% males, and the performance status are very acceptable, 0 in 80%. About 97% are 90 T3 and T4. So, and in terms of the efficacy, the DFS, 3-year DFS is 75.7 for the FOLFIRINOX versus 68.5. MFS is 78.8 versus 71.7. Local relapse 4.8 versus 7. And resection status, YPT 0, 28.3 versus 12.6. YPN 0, 82.6 versus 67.4. And these are all highly significant. So if you look at the DFS prognostic factors and quality of life, for FOLFIRINOX, a hazard ratio is 0.68. In the stratified and unstratified is 0.69. For the TNM, 16.64 for the stage 4 and 1.03, and this is also significant. Whether the tumor location, upper rectum or middle rectum, and of course the T stage as well as the baseline clinical T4 stage. Both study arms showed significant improvements in overall global health quality of life over time, with a trend toward greater improvement with FOLFIRINOX plus CRT plus TME. So their conclusion, intensification of chemotherapy using FOLFIRINOX significantly improved outcomes compared with preoperative chemo-RT in patients with clinical T3 or clinical T4 M0 rectal cancer. Significant improved DFS in the neoadjuvant chemotherapy group and decreased neurotoxicity indicate that the perioperative approach is more efficient and better tolerated than adjuvant chemotherapy. Now we go with the RAPIDO trial, which is the preoperative short course radiotherapy and chemotherapy for locally advanced rectal cancer. Again, this is randomized international phase 3. Patients locally advanced rectal CA who meet the inclusion criteria of primary adenocarcinoma of the rectum, 18 years or older, absence of distant mets, MRI with high-risk features, which means T4AB, extramural vascular invasion, and 2 mesorectal fascia plus enlarged lymph nodes. They were randomized to SCRT, which is short course radiotherapy, 5 times 5 gray, and versus the standard, which is capecitabine-based chemo-RT. For the SCRT, this was followed by 6 cycles of CAPOX or 9 cycles of FOLFOX, and then followed by TME. Whereas the standard capecitabine-based is followed by TME, then followed by 8 cycles of CAPOX or 12 cycles of FOLFOX given adjuvantly. Endpoints, primary disease-related treatment failure, and these are the secondary endpoints. So if you look at the disease-related treatment failure, it shows the difference of 30.4% for the standard versus 23.7% for the experimental. In terms of distant metastases, higher also for the standard at 26.8 versus 20.0. For the local regional failure, they're almost the same. Their rapido conclusions are a lower rate of disease-related treatment failure as a result of a lower rate of distant mets in high-risk uh, LARC patients can be achieved with preoperative short-course radiotherapy followed by chemotherapy and then TME done by conventional chemo-RT. The high pathological complete response rate achieved with the experimental treatment can contribute to organ preservation. Now we go with the lungs. Uh, uh, these are the T1, T2, T3, other than N2 nodes positive M0, induction systemic chemotherapy plus or minus radiotherapy. So these are the preoperative systemic chemotherapy. So I won't go through all of them, they're very long. So neoadjuvant systemic therapy, but what we know now is, of course, we have immunotherapy and TKIs in the armamentarium. So these are the neoadjuvant systemic therapy as well. We go to checkmate 816, which is neoadjuvant nivolumab plus platinum chemotherapy for resectable stage 1B to 3A non-small cell lung cancer. Again, open label phase 3 trial. Patients newly diagnosed resectable 1B to 3A, no sensitizing EGFR mutations or ALK alterations, randomized to nivolumab 360 milligram every 3 weeks plus chemotherapy every 3 weeks versus chemotherapy alone, followed by surgery within 6 weeks post-treatment and optional adjuvant chemotherapy plus or minus RT. Primary endpoint is pathological CR by the blinded independent review board and EFS also by the BICR. These are the secondary endpoints as well as the key exploratory endpoints. So there are 179 patients for both arms. This is almost an Asian study. About 50% of the patients come from Asia. Only 29% male. Histology, about 50-50 for squamous and non-squamous. And then most of them are in terms of PDL1 expression, 44% less than 1% PDL1 expression, only more than 50%, 21%, 21 for nivolumab and 24 for chemotherapy. And then also with the TMB, less than 12.3 mutation for MB, 27 and 30, more than 12.3, 22 and 21, which is comparable. So if you look at the pathologic CR by the blinded independent review board, it shows a huge difference, 24 YPT0N0 in the intent to treat population versus 2.2, as well as those in patients with resection, 30.5 versus 3.2, and primary tumor only in ITT, 25.7 versus 2.8. So pathological CR is defined as 0% residual viable tumor cells in the primary lung tumor as well as sampled lymph node population. So the pathological CR by subgroup analysis shows you all in favor of nivolumab plus chemotherapy, all to the right of unity, regardless of stage and PDL1 expression. And then if you look at the overall response rate and radiographic downstaging, it shows you also it's in favor of the nivolumab plus chemo versus chemotherapy alone. So you even have PR and CR of 96% for the nivolumab and only 67% for the chemotherapy alone. So in summary, checkmate 816 is a landmark clinical trial which met its primary endpoint of pathological CR with the addition of nivolumab to neoadjuvant chemotherapy for newly diagnosed resectable stage 1B to 3A non-small cell lung cancer. The benefit is consistent across all analyzed subgroups. Major PR and overall response rate also improved. However, the data is immature for EFS, which is a co-primary endpoint. It demonstrates a tolerable safety profile without adversely affecting the feasibility of surgery. And of course, this is the first phase 3 trial demonstrating benefit of neoadjuvant chemotherapy plus neoadjuvant immunotherapy plus chemotherapy for resectable non-small cell lung cancer. And these are the other ongoing phase 3 trials for neoadjuvant chemotherapy using Keynote, Empower 030, Agent, Checkmate 777, and these are the other, of course, pembrolizumab and with a combination of with pemetrexed and as well as atezolizumab. Now we go with head and neck. So for stage 4A, 4B nasopharyngeal carcinoma, as well as those with oligometastatic disease, induction chemotherapy is recommended with the preferred regimen being gemcitabine plus cisplatin for Epstein-Barr virus associated or docetaxel cisplatin 5-FU combination. It has to be noted that these regimens are category 2 for non-EBV associated disease. Gemcitabine and platinum induction chemotherapy in NPCA, patients with loco-regionally advanced stage 3 to 4B NPCA, 480 patients. Primary endpoint is recurrence-free survival. Secondary endpoints are OS, treatment adherence, and safety. In this trial by Zhang, induction chemotherapy using gem plus cis followed by chemo-RT included patients with 3 to 4B, and of course, a median follow-up of 42.7 months. So the 3-year recurrence-free survival is 85.3 versus 76.5%. 3-year OS is 94.6 versus 90.3%. Adverse events, grade 3 to 4, higher for the induction chemo plus chemo-RT, which is 75.5 versus 55.7. So induction chemotherapy added to chemo-RT significantly improved recurrence-free survival and overall survival as compared to chemo-RT alone among patients with loco-regionally advanced NPCA. Now we go with among the different head and neck cancers for hypopharyngeal, glottic, and supraglottic laryngeal, induction chemotherapy is recommended depending on the stage, and the recommended preferred induction regimen is docetaxel plus platinum plus 5-FU. So these are the induction chemotherapies for EORTC, PF versus TPF to RT. PFS is 11 months versus 8.2. OS is 18.8 versus 4.5. So compared with the standard regimen of platinum FU, induction chemo with the addition of docetaxel improved PFS and OS. With the GORTEC, induction chemotherapy is PF versus TPF, going to T or versus RT. There's a 5-year larynx preservation of 74% versus 58.1%, and a 10-year larynx preservation of 70.3 versus 46.5. So induction chemotherapy with TPF increased larynx preservation and larynx dysfunction-free survival. Now we go with gastroesophageal. So this is adenocarcinoma, high-risk lesions, lymphovascular invasion, more than 3 cm, poorly differentiated, and these are given preoperative chemo-RT for planned esophagectomy, and this is a category 1. So these are the cross-trial, resectable C2, clinical T2, T3, the SWOG, which is adenocarcinoma of the esophagus, and CALGB's esophageal, stage 1 to 3 esophageal cancer. The intervention, weekly paclitaxel plus RT plus surgery versus surgery alone. For SWOG, FOLFOX plus RT. For CALGB, cis-FU plus surgery versus surgery alone. The outcome, median overall survival, 49 months versus 24 months. Hazard ratio of 0.657. Resection rate of R0 is 92% versus 69%. For the SWOG is 28.3 months with 28% pathologic CR. And for the CALGB, it's 4.5 years versus 1.8 years. Phase 3 is cross and CALGB, and their conclusion is there's improved OS and disease-free survival, and there's a long-term survival advantage for the 2 phase 3 trials. Now we go with the squamous cell carcinoma. So this is esophageal squamous cell carcinoma. So induction chemotherapy is FU followed by surgery versus induction chemotherapy and then CRT. 2-year PFS, 64% versus 40%. No difference in OS, higher treatment-related mortality. And then adding surgery to chemo-RT improves local tumor control but does not increase survival of patients with locally advanced esophageal squamous cell carcinoma. Tumor response to induction chemotherapy identifies a favorable prognostic group with these high-risk patients regardless of the treatment group. And for the FFCD, it's respond to chemotherapy, no benefit for the addition of surgery after chemo-RT compared with the continuation of additional chemo-RT. For the neo CR-TEC, improved survival over surgery alone among patients with locally advanced esophageal squamous cell carcinoma. Now we go with the pancreas. There is limited evidence to recommend specific neoadjuvant regimens of study, and practices vary with regard to the use of chemotherapy and radiation. If neoadjuvant therapy is considered a recommended, treatment at or coordinated through high-volume center is preferred when feasible, or participation in a clinical trial is encouraged. But we go with pre-OPANC 1. This is a neoadjuvant chemo-RT versus immediate surgery for resectable pancreatic cancer. Again, this is international randomized, resectable or borderline resectable, defined as no contact with the superior mesenteric, celiac trunk, or common hepatic arteries, and less than 90-degree contact with the superior mesenteric, portal vein, less than more than one or equal of the following are required, less than 90 degrees contact with the superior, again with the, and common hepatic arteries, and no occlusion. So randomized to GEM, followed by GEM-RT, followed with GEM alone, then surgery, and GEM times 4. And the other one is GEM, is randomized to surgery, followed by GEM adjuvantly. Primary endpoint is overall survival, 16 months versus 14.3 months. And of course, this is hazard ratio is 0.78, but this is not significant. But the RO resection rate is significant at 71 versus 40 at a p-value of 0.001. And if you look at the metastasis-free interval in months, 17.4 versus 12.5, that's not significant. For local regional failure-free survival interval is not reached for the preoperative radio chemo-RT, and 13.4 months for the immediate surgery, and that's significant. Now we go with the bladder cancer. So for bladder cancer, there is the VESPER trial, which is a phase 3 trial of perioperative chemotherapy with dose-dense MVAC versus gemcitabine plus cisplatin in patients with MIBC. So these are patients with pure or mixed urothelial bladder cancer, no neuroendocrine included, eligible for platinum. If receiving neoadjuvant treatment, they should be more than T2 and 0. If receiving adjuvant, there should also be pathologic T2 or N+. So neoadjuvant or adjuvant MVAC every 2 weeks times 6 cycles, and neoadjuvant or adjuvant GEM. I have a time already. So now this is a resurrection of the combination of MVAC. So this is methotrexate 30 milligram per meter square day 1 with vinblastine, doxorubicin, and cisplatin. And this is given every 2 weeks, and then versus gemcitabine and cisplatin. So these are the baseline characteristics. 80% are male, 88% and 89% were given neoadjuvant treatment, so a big percentage. 90% are clinical T2, and then of course cystectomy were performed in 90 and 91% of patients. So this is very good results for this VESPER trial. So the 3-year PFS numerically improved with the intent to treat population, and significantly improved in the neoadjuvant treatment group with the dose-dense MVAC versus GEM plus CIS. The organ-confined response, which is a YPT3N0, occurred at significantly higher rate with the dose-dense at 77% versus 63%. Results, though, were inconclusive in the adjuvant treatment group because of the very limited sample size of only 56 patients. So their conclusion, the ongoing VESPER trial comparing perioperative dose-dense MVAC versus GC in patients with MIBC, the use of the neoadjuvant significantly improved PFS versus the GC. 3-year PFS is 66 versus 56%, numerically improved in the intent to treat analysis, and time to tumor progression significantly improved in the ITT population and neoadjuvant group also. Overall survival data, of course, still is immature. The investigators thus conclude that dose dense MVAC should become the standard of care for neoadjuvant treatment of patients with MIBC. These are the ongoing trials with the use of the PD-1 and PD-L1 inhibitors in the neoadjuvant setting for the bladder cancer. This is because of the established role of immunotherapy in the adjuvant and metastatic setting. So our key takeaways: neoadjuvant therapy provides treatment at the earliest opportunity. Neoadjuvant therapy may be more reliable than adjuvant therapy, particularly if local therapy is challenging and recovery is difficult. In some settings, tumor shrinkage of visible disease may make it possible to pursue a curative approach that was not possible with a larger cancer. And neoadjuvant therapy allows for measurement of systemic therapy effect on visible disease, which is correlated with long-term outcomes. Thank you. Cancer is an ugly disease, but the beauty of life after cancer is worth fighting for. So choose wisely. Thank you.